So let's go back to the point, and Masatoshi, I'll ask you, because exactly as we heard from Arndt, is he would be keen on, if there's a resection, is to make sure that we take care of the hepatitis C. So please tell us, what's your current practice in regard to the treatment of hepatitis C in Japan?
Hepatitis C, usually we, of course, all the hepatitis C patients with compensated cirrhosis or chronic hepatitis, we eradicate by antiviral therapy. And after, if the patient receive a resection or ablation with still the HCV positive, of course we perform, we treat with antiviral therapy. So, but there is so another. I remember another trial that performed Masatoshi performed the interferon as an adjuvant setting.
Correct.
But in a short period, there is no effect for suppressing the recurrence. But for the long term, there is an effect for suppressing the recurrence, which means secondary carcinogenesis was suppressed. So the DA therapy, antiviral therapy, I think many people think in the long run the secondary carcinogenesis will be suppressed, but not intrahepatic metastasis.
No, that's a great point that you bring up, because remember, there's one of the arguments in regard to performing transplant on patients with hepatitis C, especially because there's a concern about the bad soil, as Rich just mentioned to us per se. So that's a very, very important point. I think we probably all will agree that if we have a resection, a curative intent, there's hepatitis C to treat it. But Rich, I have a question for you. What's your thought in regard if somebody has systemic disease and actually advanced HCC, metastatic HCC, would you give antiviral therapy for hepatitis C?
You know, I don't think that most people would treat those patients. There's a cost-effective question, right? It's very expensive, and these patients won't live long enough to see a benefit from that systemic treatment.
And I think there's no data anyway, like
for sure,
in regard to safety or even value.
Yeah, you know, safety, I suspect, is probably okay. Then again, it has been extensively studied. The studies with the DAAs excluded patients who had liver cancer. But to be honest, as we see that there are some patients who are doing very well with some of the systemic treatments, it does come into play over time, right? You know, look, this patient is on a certain side of the curve. They're a long survivor. Maybe it is considered for some of those patients.
Fair. I hear you. And Arndt, would you treat anybody with hepatitis C if they have metastatic disease? What's your thoughts?
I think it's really difficult to address. So first of all, I mean, there are some data on patients that have metastatic disease and have received treatment, antiviral treatment, and they have shown that the response rate or sustained viral response rate is not as good as for patients without tumor, so it's just around 70%. I mean, usually would expect almost 100%. So, I mean, it's obviously not as easy to treat these patients. I mean, they are a little bit more difficult to treat, but still, I mean, huge success rate, 70% is not bad. So actually, so should we treat patients? I don't know. I think at the moment we are not doing it. On the other hand, I mean, for hepatitis B, I think we can all agree on that patients with hepatitis B will be treated and that they have a benefit from the treatment and that the outcome is better for those patients that receive antiviral and anti-tumor treatment. So I wonder why would that be different in hepatitis C? Yeah? In respect of immunosurveillance after curative treatment, I do get the point that there could be something, but if they have metastatic disease, and if we have no effective drugs available and patients live longer, most likely, I could imagine that it could be worth to also treat these patients. But clearly, to address this point, we would need prospective clinical trials.
No, I hear you loud and clear. If anything, I totally agree. And we're going to come to that point a little bit later as we talk about therapy. But for hepatitis B, by all means, we definitely got to treat. The virus got to be under control. In regard to hepatitis C, really, there's no clear understanding. And if anything, as we already heard or suggested, that there's no data that really talks about treating hepatitis C in the setting of the presence of systemic HCC. As we heard from Dr. Fenn, really the data doesn't even exist in that regard because because those trials included patients with HCC. If anything, there's even data that talks about potential that you might actually worsen the cancer by the treatment, even though this is extremely limited data that came from few reports here and there. So I would say that still the idea is that, as we also heard the suggestion, a Hep B is an active virus. It really can integrate in our DNA material, and getting rid of the virus will be very critical per se. On the other hand, the Hep C really, it causes certain damage. It's an RNA virus. It causes certain damage, and really afterwards, it's really the damage itself that becomes the problem, not the virus per se. And as such, really, it's understandable why the applicability or the usage of antiviral therapy for hepatitis C in the setting of metastatic HCC will require probably further data or further analysis or clinical trials, which we don't have at this point in time.